And good evening. Thank you so much for watching HealthLine on PBS Fort Wayne. I'm Mark Evans, in for Jennifer Blomquist tonight. Thank you so much for watching. Tonight, a very, very important topic, especially for women, and it does affect some men. We're talking about breast cancer and mammograms, the early detection saving lives. And with us, a very special guest back after about a year and a half without seeing us, but it's wonderful to see us, Dr. Patricia Clark. She is a breast surgical oncologist. And I understand the last show we had was very, very interesting and very informative and very important. So we're so glad to have you back.
Well, thank you for having me.
Absolutely. And before we get started, Doctor, I want to go ahead and remind everyone we have a couple of ways that you can call in with your questions or concerns. And the phone numbers will be on your screen throughout the program. Number one is you can just simply give us a call from your cell phone. And you can let us know what question you'd like to ask, or you can stay on hold for just a short while until we get to you, and we'll bring you on the air with your question live. The other way is the good old texting method. So wherever you're from, give us a text, and that number is on your screen as well. Ask your question, and we'd really appreciate if at least you give us the location you're calling from and your first name so we can address you and do a nice shout out to your town or your city from where you're calling. So let's go ahead and get started. Mammograms. First of all, a little history. How long have mammograms been around? Oh no, I threw you a curve.
Stumped me on the first question.
I'm so sorry. And we talked a little bit about what we were going to talk about in the green room. And that question just popped up in my head because I was wondering how people were diagnosed before mammograms.
Now, that's actually a great question. And you'll hear people talk about operating on cancer, and that spreads it because you opened it to air. And what used to happen before mammograms, before the x-rays, all of that, is by the time a cancer was large enough to be detected, it had already metastasized. Okay. So we would go and do surgery, and then the patient wouldn't do well. They may die shortly afterwards. So that's how that myth sort of got planted in people's brains.
Okay.
And then, the mid-20th century, we start getting more of the mammograms and that type thing. And then more recently, mammograms are widely available now. So our survival rates from, say, the 1950s until now are extraordinarily improved, but we detect these cancers when they're very small before they've had a chance to spread, and that's driving a huge part of the survival. I see.
So probably since maybe the 60s or 70s, mammography has actually become fairly popular, and utilized quite a bit.
Yeah, and we were using them in the 60s and 70s, but they weren't as widely available as they are now. And then the mammography technology has improved quite a bit. It used to be just 2D mammograms, which you can still find that some places, but in the United States, the standard of care now is a 3D mammogram, so that has a much better detection rate. And then the other thing is it doesn't misread as often.
So are we talking about radiation methods, or is it more of a CT scan?
This is the 3D mammograms take pictures like separate slices through a breast, sort of like a CT scan does.
Okay.
It's not an actual CT, but CT scans work by imaging slice by slice by slice. So the tomosynthesis, or the 3D mammogram, does the same thing. All
right. And I also, just to stress the importance of this program tonight, want to talk about some facts and figures. Do you have any stats you can share with us to
There's a couple that I think are pretty important. I hear a lot of people that are a little reticent to get screened because they don't have any family history of breast cancer, and they're healthy. They don't feel they're particularly at risk. But 1 in 8 women are going to get breast cancer.
1 in 8?
1 in 8. So the average 40-year-old walking around has over a 13% chance at some point in her life she will get breast cancer.
Oh my.
Yeah.
Oh my.
Yeah.
Well, and then I also read, which I'm hoping with people like you, professionals like you, we can get this number skewed down a bit, but it's projected about a little more than 42,000 women in the United States will die of breast cancer this year.
We have, in the United States, we have about 370,000 women will be diagnosed with breast cancer. That 40,000, those are not people who get breast cancer this year and then are going to die of it. Some of our treatments are becoming much more refined and targeted to where we now have people living 10 years with breast cancer, and 20 years ago that wasn't happening.
Okay, and I understand there's more than one type of breast cancer. Are you able to?
There are. So we have some buckets that we subclassify the breast cancers into.
Okay.
The majority of them are what we call an invasive ductal carcinoma, arising from the milk duct and invading outside that duct and into the breast tissue. We have some that are like ductal carcinomas in situ, which those are just stage zeros. Those are cancerous cells confined inside a milk duct. And as long as they stay there and they never go anywhere, they can't hurt anybody.
Okay.
The problem is some of those are going to progress to become the invasive that has the ability to spread throughout the body. We still don't know exactly which one of the ductal carcinoma in situ have that capacity and which don't. We're honing in on it. There are many subtypes like lobular carcinomas and metaplastic carcinomas. When I think of cancer, my treatment algorithms sort of are based on this, but cancer is a molecular problem. Our DNA is mutating every single day, every minute. If I go outside, boom, 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 the sun's going to break strands of DNA. We have genes that can fix all that broken DNA. One of those genes is the BRCA gene, like Angelina Jolie had. In her, that gene was mutated in a specific spot that disabled it. So she had an 87% chance she was going to get breast cancer at some time in her life. After she had her children, she actually chose double mastectomies to prevent that.
Yeah.
On these cancers, in order to get a cancer, you have to have a lot of mutations at very, very critical pathways in that particular misbehaving cell for a cancer to occur. It's got to be able to hide from your immune system. So most people with breast cancer or any type of cancer, nothing's wrong with their immune system. The immune system doesn't even know it was there. If the immune system did know it was there and the body couldn't repair the defect in it, the immune system would have killed it. You have to have mutations that allow the cells to grow uncontrolled and divide uncontrolled. For a cancer to be able to metastasize, that may need a whole nother set of mutations. So when we look at cancer now, every single cancer has its own unique fingerprint. And what's happening in treatment, and COVID actually helped this, what's happening is we're able through testing to get more and more precise about the individual mutations that a person's cancers have and how to target our therapies to them. I think I was telling you before, 20 years ago, if somebody told me I would be a breast surgeon, no way. Back then, I didn't like doing breast surgery because the surgeries were fairly crude. We would do a lumpectomy and just remove the tumor, but we would never fix the defect that we made. Everybody with a 1 centimeter cancer got chemotherapy. Now we know almost none of those people needed it. We took everybody's lymph nodes out, which could lead to arm swelling. Now, women 50 years old and over, we look at every one of them to figure out if we even need to do that anymore.
Oh, wow.
We used to, if there was a lymph node that was positive, people got chemotherapy. Now we do genetic testing of the tumor itself to determine whether you need chemotherapy or not.
Oh, I see.
And I get a lot of people that are afraid, they're a little afraid to be screened because they're afraid of what they might find.
Right.
Our most aggressive cancers, if we can find those small enough, you don't need chemotherapy. So the chemotherapy has to do with the biology of that tumor and its own mutations. But this is why I'm sort of here to champion this early detection and screening. We've reached a point where for most women, this breast cancer treatment is kind of a blip in their lives and they go on. You know, some of these cancers, unfortunately, that's not the case and we can get a tiger by the tail with some of them. But
right.
for most women, that's
well,
not the case.
Unfortunately, we only have a half an hour, or else we would go down each one. I see more than a dozen different types of breast cancer. What would be the most common that you come across?
The most common is the invasive ductal carcinoma.
Invasive, okay.
And when we look at the invasive cancers, we test for 3 different proteins on them. Do they have receptors for estrogen? Do they have receptors coding them to bring in progesterone? And this HER2/neu protein. And most of these cancers will have estrogen receptors on them, which is nice as a target to keep people from recurring. If the estrogen receptor positive tumors are usually a little bit more benign, they don't spread as quickly. It's not uncommon to see somebody who's had one of these cancers for 2 or 3 years and it still hasn't spread. If they don't have any of those proteins on those are the bad actors that have the ability to mutate, and not mutate, but they have the ability to spread, and those are the ones who need more aggressive treatments.
All right. And whether they're the most common or some of the more rare breast cancers, are they all detectable through mammography?
Actually, they're not.
Oh.
So everybody's nightmare, and I think everyone has an anecdote where they've heard of somebody where they got a mammogram and they didn't find it. The invasive lobular carcinomas, those don't form a nice, solid, tidy tumor that's easy to see. The cells sort of line up in a row. So particularly if somebody has dense breast tissue, those can be missed. And when I find those, a lot of times a woman can feel a lump, or she says her breast is changing. She may have pain, which pain is not common with breast cancer. Most breast cancers are pain-free. Oh. But usually the woman has found something. And then I have other imaging other than a mammogram. If I have a suspicion or something isn't lining up exactly right, I can do something like an MRI. And breast MRIs are specialized, where we have a special coil there, but we give an IV dye, and the cancerous cells pick up the IV dye at a different rate and hang on to it longer than a normal cell. So we also do this for extremely dense breast tissue, or breasts that are very complicated with a lot of cysts, where it's hard to find, is there something bad happening there, or is this just normal sort of chatter? But anyway, yeah, we have additional imaging modalities for these ones that are harder to detect. And an MRI is not something that somebody should just go do just in case, though. Right.
Well, I'm got several questions regarding the the mammogram process, but I want to skip ahead here. Who should be getting these mammogram screenings?
So you'll hear a little bit of controversy with different guidelines, but all the major, like the American Society of Breast Surgeons, the American College of Radiology, everybody age 40 on should have an annual mammogram. And then one of my particular interests is, when should people stop? And there are some guidelines that say after age 70, stop. Well, our patients are living to age 90 and still driving their car. That's 20 more years.
Yeah.
The age 70, that might have been true on studies that were done 30 years ago. If somebody has less than 10 years of life left, they can consider stopping. But I see a lot of women come in actually in their 80s, and they may be in their mid-80s, and they have cancer. Nobody checked them since they were 70 years old. If you are healthy, keep getting the mammograms.
And how often?
Once a year.
Once a year?
Once a year. And then there are other high-risk people. If somebody has a family history of breast cancer, we recommend they start the mammograms 10 years before the age that of the youngest person with cancer. So if mom had breast cancer at age 40, then they should get their first mammogram at age 30. We don't do mammograms on women in their 20s, and one of the reasons is the breast tissue is so dense that it's very hard to interpret. Everybody at age 25, though, should have their primary care doc do a risk assessment on them, see what their family history is. We're actually seeing increased rates of breast cancer, and even in young women nowadays. We're not sure exactly what that's coming from, but there are several things that we do know drives that. One of them is women are delaying childbirth quite a bit. So there, there used to be everybody had the children when they're 20.
Right.
Now they're 30, 35. So the longer you wait before you have your first child, that increases the risk. And then the other thing that increases risk is obesity. And we have quite a weight problem. These estrogen-driven tumors, fat cells make estrogen. So that's one of the predisposing factures. And then there are others such as exercise, lack of exercise. There can be environmental things. Some people may even have some just little genetic quirks in themselves or their family that is not necessarily a gene that we pick up with genetic testing.
All right. So, we do have a text coming in. It's from Sophie, and she's from Auburn. Thank you, Sophie. She's saying, my father and my sister both had mastectomies with recurrent breast cancer on their mastectomy several years later, I guess. My question is, people with bilateral mastectomies, how are they screened? How are they going forward, since it is possible to redevelop the cancer after that mastectomy?
So that is a great question.
It really is.
When we do a mastectomy, generally the subcutaneous tissue, we remove all of the breast tissue. So all we're left with is the skin and usually no more than 1/2 inch of subcutaneous tissue. Because there's no deep tissue there, if somebody develops a recurrent breast cancer, even the size of a pea or a peanut, you will feel that. So we don't do any imaging. On somebody that's complicated and has had multiple recurrences or something, that may be a different story. But the average normal person with a mastectomy, you don't need to do imaging. You can do a physical exam, and this is something people can even do in a shower, where you just rub the hands over the chest, and if you feel a knot or a nodule, then you come in to the breast surgeon or the radiologist. Will ultrasound it, will biopsy it. And so we can detect recurrences when they're still very, very small after a mastectomy.
And she hit on a very good point. Men can actually get breast cancer as well. And so do men get mammographies?
So men don't require screening mammographies. This family history, when you have a man with a breast cancer and another family member with a breast cancer, such as our caller, those are the people that we worry about having a genetic mutation like this BRCA mutation. Men that have a mutation like that, they absolutely should be screened. We only have about 1,500 men a year in the United States develop breast cancer, so we see quite a few of them here. With men and breast cancer, what generally will happen is there'll be a little bit of breast tissue right behind the nipple areola complex. So if that starts getting hard, it starts getting red, it starts getting scaly, something becomes abnormal there, that's when they should absolutely check it out.
All right, very good. Glad we addressed that. Another text coming in from James of Fort Wayne. How hopeful are you for future of the cancer treatments?
That's another great one. I am very hopeful, but if we go back to his question, he said something about, are we going to, can we find a cure in the next 20 years?
Yes.
No, we will never find a cure, because the cancer is not a single disease. The cancer, if you figure out how many millions of molecules make up the DNA molecule, that is in every one of our cells, and how many mutations can happen in there. Every one of these cancers has its own unique fingerprint, so there's not a cure. If we were going to cure cancer, we would probably be immortal. We would have to have so much control over every single chemical reaction that happens in our body and every little alteration and just us wearing out. So there's not going to be a cure. What there is going to be, and this is why I'm so excited about my profession, as we understand more and more of the genome and molecular genetics and immunotherapy and all these things, we get more and more precisely targeted to where we can knock these cancers out. Jimmy Carter was a great example of this. Jimmy Carter had melanoma.
Yeah.
He had melanoma that when I started my career, that was 100% fatal.
Wow. But
they found the molecular key to his particular melanoma. Boom.
Yeah, and he
Killed
lived to
it.
be 100 years old.
He lived to be over 100 years old. And that's happening. Some of our most aggressive, like the HER2 positive cancers, this is a protein on them. When I started my career, that was one of the most deadly cancers you could have. Now, if somebody comes in with that, we give them chemotherapy right up front. I don't even operate right away. We give that chemotherapy. By the time we're done with that chemotherapy, between 60 and 80% of those patients don't have a trace of that cancer left.
That's
I just
wonderful.
go in and do a little surgery and take out where the biopsy clip was and proved it's not there anymore. And those patients do fantastic.
Wow.
One woman came to me, she was over 100 years old with that cancer, and I put her on that chemotherapy, and it didn't even knock her down.
Wow.
It's that. So, you know, the future, as long as we can keep research, as long as we will fund research in the United States, a lot of these cancers we're going to be able to get control of.
I'm so glad to hear that. Another call coming in, looks like Sophie from Auburn, and we'll bring that question up. What if they have implants after a mastectomy? How do you screen?
So the same thing with the implants. With the implant, you've got maybe a ½ inch of tissue, and then you've got a breast implant under that. Most of the recurrences are going to occur in the skin or in that soft tissue. Less than 5% are going to be on that muscle behind the breast implant. Mm-hmm. So we don't need to screen after an implant. And the implant actually stretches that skin a little tighter to where any irregularity or lumps in there are even easier to detect.
All right. And just for those who don't know or have never gone through the procedure, would you explain what someone can expect from that experience as doing a mammogram?
Yeah. So there's generally the size of a big exam room, and there's an upright machine in there. And then the mammography machine has 2 plates, and yes, women get squeezed. The technologist will position the breast so that they can see all the way back to the chest wall, because if you just get the front of the breast, you may miss what's in back. The plates will squeeze down, and then they have a pressure sensor on them to where they're going to stop at a certain point. And having been a veteran of multiple mammograms myself, I've had some where I happened to be tender that day. I've had plenty others where I didn't. That's sort of an individual thing. It should not be painful, but as many women will tell you, sometimes that's tender. Mm-hmm. So,
sure.
And it lasts probably 5 minutes or so. They take multiple views, and I know some people have some mobility issues.
Right.
A lot of times you can use a cane, you can use a walker, and some of the mammography machines they're adjustable up and down to where even some women in wheelchairs can go in them. Mm-hmm. Yeah, when we have people that are completely prone, that can become a problem because we can't get them up close enough to that machine.
Right.
To get that done.
Right. Well, we only have a couple more minutes left, and you've been so informative. We truly appreciate it. But if one wouldn't want the radiation, can they just have an ultrasound?
No.
No.
So no, we get that question a lot. So it's interesting. Our 3 main imaging modalities are the mammogram, the ultrasound, and the MRI. And they each do something completely different. The mammogram, we can see a solid tumor on it. We can also see calcifications. And a calcification tells us something died right there, and that's part of the little scar of that dead cell. When we get into these ductal carcinoma in situs, which are like the stage 0, those don't even have the ability to bring in a blood supply to nourish those rapidly developing or growing cells. So some of them will die, and we'll see the calcifications. We can't see that on an ultrasound at all. The only thing an ultrasound will show us is a solid mass. Some of the lobular carcinomas, we wouldn't be able to see that on an ultrasound. Ultrasounds are useful if we're trying to figure out if we see something on a mammogram and we're wondering whether it's solid or it's cystic or fluid filled. The ultrasound will tell us that. The ultrasound is pretty good at telling us the size of a solid mass. It can pick up about 4 more cancers per 1,000 when you add it on top of a mammogram, but it absolutely won't replace it. Mm-hmm.
Okay, and if you have particularly more dense breasts, are they going to need extra imaging?
So it depends. So we have like 4 classifications of breast density. It goes like A, B, C, D. Most women actually have, over 50% of women have dense breasts. So it's normal. It can make it hard to tell if everything's white. You don't know if there's a white mass hanging out and all the rest of that white. So this becomes an individual thing. The 3D mammograms that we do now, those are fairly good for dense breast tissue, but the patient's doctor or breast surgeon or whoever may decide if somebody has very dense breast. Some people will benefit from having an ultrasound added on top of that, particularly if they have a lot of fibrocystic changes and things that just make things a little busy and cluttered, then that's good. The extreme breast density, where everything's whited out, those we will even look at with an MRI.
All right. Well, we thank you so much for being here. We're running out of time. I want to remind our viewers you can rewatch this episode as well as other HealthLine episodes on our website and on YouTube. Again, thank you to Dr. Patricia Clark for being here, and we hope to have you back again soon.
Oh, thank you very much.
All right. Until next time, thank you for watching. Good night and good health.
The preceding program on PBS Fort Wayne is made possible in part by